shapes on the best fit. If I want to study the shape of the elevation map, I have to use the best fit sphere, not the best fit toric ellipsoid. It should be the sphere. So on the sphere, we have hourglass and we have central island. Both are symmetric. Asymmetric shapes, we have the skewed, but there is no definite number. It is not like the curvature map. We cannot say that if the skew is above 22 or below 22. Tongue-like extension and irregular hourglass. We have to look at numbers also on the elevation map. There are two ways. The first way is to use the best fit sphere, and the second way is to use the best fit toric ellipsoid. If we want to use the best fit sphere, we have to look at the number corresponding to the thinnest location. This is the symbol of the thinnest location. The number corresponding to the thinnest location, and according to Ambrosio-Bellin, these are the cutoff points according to anterior and posterior and according to myopic and hyperopic. To simplify these numbers, for example, for the anterior curvature map, if the number is above 8 and the patient is myopic, it is abnormal if it is above 8. For example, for the posterior surface in a hyperopic patient, I can accept until 28 microns in the number corresponding to the thinnest location. The other one is very simple. We can use the best toric ellipsoid, and if the map is for the anterior surface, we can accept until 12 microns, and for the posterior surface, we can accept until 15 microns. This is within the central 5 millimeter. Central 5 millimeter, any plus. Minus is not important, but plus values are important. So it is high risk when the corresponding point is above these cutoff points, or if I'm using the best fit toric ellipsoid, it is high risk when we have above 12 for the anterior or above 15 for the posterior within the 5 millimeter. We have to study both modes. It is not sufficient to study the best fit sphere or the best fit toric ellipsoid, because sometimes it is normal on one of them and abnormal on the other one. Like in this case, as you see here, if the patient is hyperopic and this is the posterior surface, it is considered as normal on the best fit sphere. While on the best fit toric ellipsoid for the same eye, we can see that there are very high numbers within the 5 millimeter, so it is abnormal. I cannot accept such a case for refractive surgery. So we have to study both. Regarding the thickness map, we have symmetric shape, which is the concentric shape. We have the horizontal displacement of the thinnest location, as you see here. There is the vertical displacement of the thinnest location, which is called dome shape or conic shape. Even here, you can see the thinnest location has very high number, -2. And we have bell shape characterizing pellucid marginal degeneration because of the inferior thinning strip. And we have the globus, keratoglobus shape. The keratoglobus, which is a generalized thinning of the cornea extending to the limbus. We have to look at the numbers also on the thickness map. We have to study these two opposing points. The normal value should be, or the normal difference should be less than 30 microns. Now, I will classify these into high risk when I find dome shape, bell shape, keratoglobus. Moderate risk when it is concentric, but the difference is above 30. We come to the spatial profile of the progression. I have to look at the shape and its relation with the 6 millimeter zone. Now, the normal shape takes its slope all along the passage without leaving its passage. And if it leaves its passage, it leaves it after the 6 millimeter. And the average should be always less than 1.2. It should be 1.1 and less. Look at these shapes. There is a quick slope. It leaves its passage before the 6 millimeter. This is S shape. It comes down, then up. which is seen in ectatic corneal disorders. And we have the flat shape, which can be seen in Fuchs dystrophy and cornea guttata, and the inverted shape, which can be seen in pellucid marginal degeneration. Now, these profiles are classified into high risk when we have quick slope, S-shape, inverted shape, and it is moderate risk when it leaves its passage after the 6 millimeter, like this one, and when we have above 1.1 in the average. The last point is the inter-eye corneal symmetry. This is a very recent study about the comparison between eyes in terms of mean anterior keratometry, mean posterior keratometry, thinnest pachymetry, front elevation at thinnest location, back elevation at thinnest location. Whenever I have a difference between both eyes in one of these points, I give it +1. And then I take the sum of the scores, and after that, I classify the case as high risk when the score is 4 or 5, and of moderate risk when the score is 3. This is the summary of all the risk factors, but you may ask, where is the low risk? As you see, high risk, moderate risk, and low risk. Actually, low risk is given for any very normal case, because as you know, refractive surgery is not risk-free. Before you judge that this case can go into surface ablation or LASIK or something else, whenever you have such abnormalities, you have to exclude some factors that may mimic such things, like if the patient is using contact lenses for a long time and he has just removed the contact lenses just before coming into the clinic. So there will be a very high warpage of the cornea. So in this case, we have to stop contact lenses for at least 1-2 weeks. And there is a rule that says 1 week for every 1 year of usage in order to retain the normal shape of the cornea before judging. And maybe misalignment during taking the capture. Maybe large angle kappa. Angle kappa will change a lot the corneal topography when it is larger than the normal. It causes a skewed radial axis, and it may cause tongue-like extension even on the elevation maps. So we have to pay attention. And of course, how to see the angle kappa, it is a big talk. We have no time for this. Now, dry eye or excess tears, also we have to exclude them and treat them before we recapture the patient. Maybe there are some corneal opacities, scars, cataract. Now, what is the relationship between cataract and the topography? Actually, for the astigmatism, whenever you see a difference between the manifest astigmatism and the topographic astigmatism, this is the point. When there is a difference, you have to recheck the patient for a subtle cataract you may have missed during the first quick slit lamp examination. And finally, you have to ask about previous corneal surgeries. Now, if I have one high risk factor or two moderate risk factors in one eye, I don't do corneal refractive surgery, corneal. Like LASIK, PRK, I don't do. One high risk or two moderate risk factors in same eye. But if I have one moderate risk factor in one eye or on each eye, either I observe the patient, ask for a family history of keratoconus, or I can move to PRK with caution. I'll give you one clinical example how I study the patient. I look at the quality specification. It is okay. Kmax is below 47.2. Thinnest location is above 500. Y coordinate is less than minus 0.5. The astigmatism, this is with the rule astigmatism. So the amount is okay. and I have to compare it with the manifest astigmatism of the patient. Q value is within the normal range, but this patient has skewed radial axis above 22 on the anterior curvature map. Although the inferior superior difference is less than 2.5. Why 2.5? Because the upper one is higher than the lower one. Now coming to the best fit sphere for the elevation map, the point corresponding to the thinnest location, it is 3, which is normal. And on the best fit toric ellipsoid for the same surface, it is below 12, which is normal. And for the posterior elevation map, still normal, because these are the number of interest. And when switching to the best fit toric ellipsoid, still normal. For the pachymetry map, the difference is less than 30, and the shape is concentric. The slope is normal, but the average is above 1.1, as you see, 1.3. So in right eye, we have one high risk, which is SRAX, and one moderate risk, which is high average. For the left eye, for the same patient, okay, Kmax is okay, thinnest location is okay, Y coordinate is okay, astigmatism, Q value, there is no SRAX less than 2.5, thinnest location, elevation map corresponding to the thinnest location is okay, and in the toric ellipsoid it's okay. This is the posterior surface, also it is okay, and toric ellipsoid is okay. This is concentric, but the difference is above 30. The slope is normal, but the average is high, 1.2. So I have two moderate risk factors in the left eye. Now I have to see also point number 12, which is the comparison between both eyes. There is a difference, so +1. No difference in this point, no difference in this point, but there is another difference on elevation maps. So it takes only +2, which is not a risk factor. So the final evaluation of this case cannot go to corneal refractive surgery. So in summary, you have to study the 12 points. You have to look for the risk factors. You have to score your case, and you have to score your case. Now, because Dr. Muhammad unfortunately could not prepare for Cyrus, and because I am a Cyrus user also, I will show you what are the different points in order to apply the things that I said on Cyrus itself. On Cyrus, the same, everything that I have said about curvature map, pachymetry map, everything can be applied on Cyrus, except the elevation maps. The way this machine gives you elevation maps is not corresponding to the best fit toric ellipsoid and not corresponding to the best fit toric, best fit sphere. It has its own way. So to switch it in a way to apply those points of pentacam on this, we have to follow these steps. We have to go to this symbol, which is called the aspherotoric symbol, and then we choose the anterior if we are going to study the anterior surface, and then we should adjust here for spherical corresponding to the best fit sphere and best DZ. In this way, this display may mimic that one, the best fit sphere of the pentacam. And if I want to see the best toric ellipsoid, I have to choose the aspherotoric, best DZ, and then those points can be applicable. I do the same for the posterior. Same steps. In addition, on the Cyrus, you have to be careful. When you see apex here, on the pentacam, apex means center of the cornea. Center of the cornea. Here, apex means Kmax, the place where the maximum K readings are. Thank you very much. Now, I'd like to invite you to join my group, Sinjab Academy, on Telegram. It contains more than 1,400 members. It is specialized in refractive surgery, topography, and keratoconus for discussions, very beautiful discussions, and you will find all my sources there. And I also would like to invite you to my course, which will be in Copenhagen, How to Improve Your Refractive Surgery Outcomes by Skillful Interpretation of Corneal Imaging, which will be in the coming ESCRS. I am from Bahrain, Arthur Cumming from Ireland, Roberto Pineda from USA, and Carl Stone Ciffer from USA also. Thank you very much.